Okay. Imagine you're in a room and there's a patient bleeding all over the floor because their transplant has gone wrong. Now the anesthesiologist is looking at you to do 10 things at once and to help assist in saving the patient. Would you be able to calmly react and prioritize all the tasks the anesthesiologist would require of you? I'm here today to tell you what an anesthesia tech does before, during, and after the surgery. What I do before the surgery. First thing I do when I walk out of the locker room is look at the board and see what surgeries are coming up for the day, see if there's any small ones, big ones, whatever I might have to prepare for. I then see who's absent for that day, my other techs or coworkers, and I see, okay, it kind of gives me an idea of who I'm going to be missing and compensate for certain things. I then stock my assigned rooms to make sure that my rooms have all the necessary supplies that they're going to need for the day to do surgeries, and hopefully it lasts them throughout the whole day. And I start getting calls from anesthesiologists and nurse anesthetists for specific tasks or items they need for surgery. And I'd say the three top things that I get asked to do in the morning is one, to do a nerve block, which is basically if you're going to have your shoulder worked on or your arm or your leg or anything, they go in, the anesthesiologist does, they go in there and they numb up the nerves that go down your arm and everything so that it numbs it up for another 30 hours or so after your surgery. Because if you have surgery and you get out and you don't have that, it can be extremely painful because they dig in there pretty deep. The second thing I would do is set up a central line access kit, which is the big IVs in the neck. And what we would do, we'd sterilely open everything up, put sterile gloves on, sterile gown, and we put everything in the proper order that the anesthesiologist would grab off the tray in order to work on the patient. The third thing I would do is set up or do the arterial lines, perform them. Basically, an arterial line is like an IV that goes in your skin, only it goes a little bit deeper into your artery, and it gives you a second by second, every heartbeat, it gives you an accurate blood pressure and heart rate. And when you're having a big surgery, it's very important to always know at every second what's happening with the patient's body and what their blood pressure is doing. And once the surgery begins, that's when the real work can begin for me, because this is all just stuff I do in the first hour that I get there. What do I do during the surgery? I get called to assist with intubating the patient with an intubation tube, which is this. This is an example of one. And this goes down into the airway so that the patient can breathe off the machine while they're under surgery. At times they will need a glide scope, which is this item right here. And what this does is a video assist blade that allows you to see down into the airway and allows you to place the tube down into the airway so you can accurately see where you're going. And funny thing about the glide scopes, they were actually invented in 2001 by Dr. Jack Pacey. I did not know this. So they're really not that old. They're only about 16 years old. You'd think they'd be a little bit older, actually. Sometimes the nurses need help placing the patient in the proper position. Once they have the airway in there, they have to maybe flip them on their side. If they're having the right hip worked on, it needs to be no pressure on it at all and exposed. So they will go in there and we'll have them position the patient, put them in the right order and everything, and pat them up. They will call me for certain supplies that they may need during the surgery, any specific things that they might need extra, maybe they ran out of. Another thing I do is I run the cell saver device, which is this right here, which basically takes red blood cells and it extracts them so they suction from the field and then it goes through the machine and it turns them into red blood cells, and it actually then allows you to reinfuse them back into the body so that the patient is actually using their own red blood cells from their body rather than some random one that gets donated, which is still fine, but this is, in some people's opinion, a better way of doing it. And what's kind of funny is that Jehovah's Witnesses, I didn't know this, Jehovah's Witnesses don't believe in major surgeries because with major surgeries you usually need blood transfusions and they don't believe in receiving other people's blood. It's a faith thing, which is totally fine. But with the cell savers, they can actually reinfuse their own blood. So some people are actually now able to have major surgeries. Some still don't agree with it, but it's good to have that option. Mm-hmm. And another thing I operate is called the Belmont, and it's a name brand. And what it does is it's a rapid infuser, so it allows you to rapidly infuse blood products or saline into this reservoir here, and then it warms them up in here and puts them into the body. And basically I would hang bags, and as they run out, you ask the anesthesiologist what new bags of fluids they want, et cetera, et cetera. Another thing I would do is help squeeze bags of fluid that are not necessarily going through the Belmont, but they're just hanging up there. If they just want to get in there quick, I just stand up there and squeeze it while the anesthesiologist can focus on other things, so they're not sitting there having to do that. When a patient starts really having problems, bleeding profusely, that's when I take on a lot of the tasks that I just discussed, such as the cell saver, squeezing blood products, or obtain supplies they need. And that's when I was talking about in the beginning, is that when you have really something going on, a patient's bleeding everywhere, you really have to multitask and you have to decide what's more important than others. And so sometimes you have to run the cell saver, and while that's running, you run over to the Belmont and you keep filling up with fluids, and then you run back to your cell saver and you keep processing that. It can be a lot. It can be a lot of stuff to do. And what I do after the surgery. What I can do after the surgery is help keep certain patients calm while they wake up, because some people wake up pretty erratic, which is kind of funny because it makes me go, I never want to have surgery around my coworkers because who knows what I'll say or do when I wake up. And another thing I do is turn over the machine after the surgery for the next surgery. Let's see, get called into the post-anesthesia care unit, which is also called the PACU, to help with certain tasks such as help diagnosing existing arterial line, because sometimes they can dampen out, is what we call it. It just kind of goes flat, but the patient's fine. They just want to assess the arterial line to make sure that it's still working properly, and if it's not, then we just put in a new one. The other thing I do is help with re-intubating a patient because they stop breathing. Sometimes it does happen. They'll go into PACU and they'll be laying there, and then all of a sudden they'll just stop breathing, their body, for whatever reason. So we have to re-intubate them and put a new tube in them. And then another thing I do is restock my rooms for the next day. And that's pretty much a nice summarization of what I do in my job. Now I've given you a brief understanding as to what an anesthesia tech does before, during, and after surgery on a daily basis. I will tell you that my job has been one of the most humbling experiences of my life. It takes a lot out of you, but it also gives a lot back. It's made me more humble and appreciative of my life and my health. I'm thankful to have been performing this job, and the life lessons I've learned will stay with me for the rest of my life. Thank you.